It's an honor to be here. I've told several of the students, as an undergraduate, I never took a psychology course. And I teach in a graduate-only program. So to be able to interact and present to undergraduates and hopefully have some influence, maybe, on how you think about things is a great treat for me. I get to talk to lots of academics. Academics are always, arguing with you, or claiming you're not right, and all this. So it's great to be able to present here tonight. And Dr. Stone, of course, thankful for your generosity for making this happen. So, I'm a professor, and they pay me to profess. So I'm going to tell you briefly everything I know about how psychotherapy works. So I'm going to get right into this. So first I'm going to tell you a story about the fisherman in Luarca, Spain. So, and this is, you'll see the connection to psychotherapy as we go on. But Luarca is on the north coast. It's near the coast of death. So this is a treacherous place to be a fisherman. The harbor has this little teeny entrance. And once you leave the protected harbor, you're in the Bay of Biscay with terrible, foul, dangerous weather. So what would evolutionists tell us about survival of the fittest? So that fisherman who has the most ability to go out on these difficult, foul weather days and be successful is going to survive, right? So this is, you would think, a survival of the fittest individual fisherman, okay? But that's not how it works in this community. So on foul weather days, and this is a picture that's on the mural in the town, they get together on the morning, and as you see on this board, they have a boat and a house. And the fishermen get together, each have one token, and they place a token either on the boat if they want to go out fishing that day, or on the house if they want to stay home. Okay? So if a majority of the people put the token at the home, everybody has to stay. Now, if the majority are on the boat, they can go fishing if they want. They don't have to. But this is a community-based decision, and so it's what E.O. Wilson calls survival of the group rather than survival of an individual. Now, there's an argument about whether that's an appropriate evolutionary concept, and actually Darwin talked about this in 1858 about survival of the fittest group. Now, kind of in an agricultural area here in the Quad Cities, and let's talk about breeding chickens for a minute. If you wanted to breed chickens to lay eggs, you would think, I'm going to take the best egg-laying chicken and breed that hen with others of the same family to get the best egg-laying chicken. Guess what? That doesn't work so well, because chickens have to exist in cages together. So if you actually breed for social characteristics, how well they get along in the cages with other chickens, you'll have greater productivity of eggs than if you just breed for egg productivity. So the social aspect of evolution is really important. So E.O. Wilson calls species that get survival of the fittest EU social animal because it's the group process that becomes important. Of course, humans are the ultimate social species, but also ants, which was where E.O. Wilson started as a sociobiologist, some species of bees, termites, one species of shrimp are EU social. So, not surprising, given the fact that humans are social animals, we heal in social contexts. So, ants do it, okay? So what happens when an ant in a colony has a virus? Well, it's at risk to die, of course, because it's sick. But what does the social colony do with the ant? Well, they actually rub up against the sick ant. So all of the ants rub up and touch the sick ant. Why is that? It gives a transfer of the virus at a small dose, creating immunity in the other ants. And evolutionists call this social immunity. So every healing power of the human individual has an analog in the social context. Bees, if there's an infected bee in the colony, we know that fevers help fight infections. Okay. Well, what the bees do is they all flap their wings really fast in the colony when there's a bee that's sick, raising the temperature of the colony, which simulates a fever in the individual bee. And that both protects the other bees, but also is healing for the bee that's infected. Why do we make that face when we're hurt? Cross-cultural. Every human being makes the same facial expression when they have pain. It elicits social support. Okay? So we heal in social contexts. When you're hurt, you need others to take care of you. If you're out in the savannah and you're hurt, you need to be taken back to your home. Okay? So we have that facial expression of pain to create an empathic response of other people who then are going to take care of it. Human healing practices. Every single society, currently and throughout history, has had healing practices with designated healers. Okay? From the ancient Greeks, Chinese, to the present, we all have our designated social healers. So the point here is that we heal in social context. And psychotherapy is probably the prime example of healing within a social context. So let's keep that as the background. Look about what we know about psychotherapy. It works. It's been demonstrated in randomized clinical trials. Students have been talking about the difference between efficacy and effectiveness. I don't like the distinction because they're both synonyms. They mean the same thing. And the distinction isn't very clear. But clinical trials, psychotherapy compared to no treatment or some kind of control group shows it's remarkably effective. Psychotherapists in practice produce outcomes comparable to clinical trials, so it works in practice as well. It's as effective as medication for most mental disorders. Antidepressants, anti-anxiety medications, psychotherapy works as well as medications, but it's longer lasting. Okay? If you withdraw an antidepressant, people relapse at a greater rate than when psychotherapy is terminated. Has fewer side effects. One of the side effects of psychotherapy is you feel better. Your quality of life is better. Okay? No sexual side effects, no weight gain, no problems in sleep. It's less resistant to additional courses. Somebody that's had a course of medication is going to find less effectiveness the second time they take it. Whereas with psychotherapy, the second course of psychotherapy is still effective. But this doesn't answer about how psychotherapy works. What makes psychotherapy effective? So, as an introduction to this, I want to show you two brief psychotherapies. The first one I want to get at, I'm not going to show all of this, but just enough to...
So let's try this, and what I'm going to suggest is...
Okay, this is Leslie Greenberg. His treatment is called emotion-focused therapy. And what he does is, the idea of this therapy is that people need to express their primary affective states. And people that don't have less well-being and more psychological difficulties. And the way he does this is, he has the patient talk to an empty chair, right? This goes back to Gestalt therapy, and Leslie Greenberg used to call himself a Gestalt therapist. Then he became a process experiential therapist, and now he calls himself an emotion therapist. This is a woman who was having a problem in her marriage. Her husband's an alcoholic. She grew up in an alcoholic household. Okay. And she's unable to express her sadness about being married to somebody who's kind of recapitulating her difficulty in life. So we'll just watch a bit of it as Les gets the patient to talk to the empty chair.
Imagine him here, if you will.
Okay.
Try, and his name is?
Carlo.
Carlo, okay. So we're going to put Carlo there, and can you actually see him? And try and stay in touch with him, not me.
Okay.
It's as though you really...
Skip ahead a little bit.
Yeah. Tell him about it. I'm not happy.
I'm not happy.
Yeah. Breathe and just let... these are important tears. It's okay. Tell him about... What are the tears saying?
Can't you see I'm hurt?
Okay, so that gives you a flavor of emotion-focused therapy, emphasizing the expression of one's affect. The second is Keith Dobson. Keith Dobson is a behavior therapist. He's working with a woman who has panic disorder. And in this segment, he's going to do a panic induction. Panic induction is kind of an exposure-based technique where you have the patient experience a panic attack in the session. So he's going to induce the feelings of panic, the constricted muscles in her chest, the difficulty breathing, the catastrophic thoughts about what's going to happen. And in this tape, it's a little interesting because it's a talk-over. He's kind of explaining what he's doing. So you hear part of what the patient does and what he's thinking about this. And I'm going to skip around a little bit.
Telling me about how her sensations end, that these sensations normally just go away, which again is the kind of information I would want to hear in order to know that doing a panic induction is going to breathe. So not deep breathe, but do shallow breathing, hyperventilating together, and we'll get the sensations together.
And now he's getting her to
You'll see that I'm setting this up with her, so it's not something I'm going to get her to do herself, but we're going to do it together. But I'm setting it up as an assessment strategy. Truth is, this is actually an assessment and an intervention because she's doing her first exposure here. But really, in many ways, it is an assessment for us. I set it up pretty quickly. I don't give her much time to do it more deeply in a second. You see her closing her eyes again, so she's doing things to protect herself. How are you feeling a little bit or more? So I'm encouraging her to push it a little bit harder because I noticed she wasn't doing it very much. till she starts to get the sensations.
That's fair enough for everyone. A few seconds, okay? Let's keep going.
And I see this.
Well, you can see her start to have the characteristics of panic disorder. She's having a panic attack, and that's part of the treatment. How can two so different treatments both be effective? Both of these treatments have been tested in clinical trials and shown to be effective. So these aren't just two therapists doing kind of crazy stuff. This is psychotherapy that's been proven to be effective. So it's really interesting how therapists doing so many different kinds of things can produce good outcomes. So we need a way to understand how it is that Leslie Greenberg and Keith Dobson both are effective therapists. So I'm an academic, so I get paid for drawing complex diagrams about how things work. So this is a model of how psychotherapy works. Okay, and we're going to go through each parts of this, talk a little bit about the research that supports it, and to give an idea of how it works. So the first part of how psychotherapy works is that a patient comes with a disorder or a problem or a complaint, okay, something that's bothering them that they want to improve. Okay? Well, the patient comes with some background, right? A racial and cultural background, economic resources, beliefs about how psychotherapy works and about why they're distressed. Meet with a therapist who also has a racial and cultural background, has a way of working with patients, a personality, right? These are two people meeting, and in that meeting then they build trust and understanding, and the patient comes to believe that the therapist has some expertise to help them. Okay, before we go into this too much detail, we're going to do a little experiment. Okay, so yeah, you're going to be subjects in my experiment. So here's the experiment. You are traveling, let's say, internationally, and you take the train to a city you're unfamiliar with. You arrive, the train's late, so you arrive late at night, and you walk out of the train station, you think you know exactly where your hotel is, and you find yourself feeling lost. Okay? So you reach for your phone to look at Google Maps, but either the battery's dead or you're like me, who too cheap to pay roaming fees, so you can't use your phone. What are you going to do? You're going to ask for help, right? You're going to approach somebody. But you have to determine if that person is trustworthy, right? Because either they're going to say, oh yeah, well you go down here and you turn left, and right? Or they're going to steal everything you have, your passport, your phone, your wallet, computer, and so forth. So here's the experiment. Okay, so we're going to divide the room right here. And on this side, you're going to close your eyes. Okay, everybody got their eyes closed? Okay, for those on the left, I'm going to show you a person that you meet, and you have to determine whether they're trustworthy or not. Okay, you ready? Finished. Okay, now you guys close your eyes. On the left, and the people on the right, open your eyes. Oh, you're so good subjects here. This is perfect. Okay, now you guys are going to see somebody. You ready? Okay, everybody open their eyes. Who thought the person was trustworthy? Majority on the left. Okay. Same person. These are actual stimuli from study at Yale University. Guess how fast we make judgments as humans about whether someone's trustworthy or 50 to 100 milliseconds. Okay, we're evolved to do this because our life depends on being able to make the right determination. Okay, ready for a few more faces? Okay, everybody can keep their eyes open. Trustworthy? You ready? We all recognize it as a face even though it's a Danish electrical plug. Okay. Ready for the next one? Not trustworthy. We're evolved to do this. We see human faces in that configuration. So humans are evolved to do this. We do it very fast. But of course, you know, when patients come, you know, I interchange patients and clients. There's some reasons for each of them. But patients come, it's not just a bottom-up processing, but it's also top-down, because we come with expectations about therapists. Somebody's told us this therapist is good. We have some confidence in psychotherapy. Many people in the United States and other Western countries think psychotherapy is kind of crazy. You see therapists if you're really crazy, not for just problems. I mean, when my parents asked me what I'm going to do, and I said, well, I'm going to graduate school to become a therapist, they kind of looked at me like, oh, it's crazy. So, but people who come to psychotherapy have some kind of preconceived notion. So there's a top-down processing as well. Much of it's nonverbal. We make the discriminations based on vocal tone, facial expression. Actually, studies of diplomas on the wall make a difference. This is a critical stage because guess when most people drop out of psychotherapy? Yeah, at the end of the first session. Okay. Second most after the second session, and so forth. So this initial impression about how well this therapist and the therapy can help the patient, absolutely. And actually, many people make significant progress in the first 3 sessions. And there's some research to indicate that actually, from the time you make the appointment to the time you present at the first session, you make significant progress. Anybody have the effect that have some symptoms and you make an appointment with the doctor, and by the time you go to the doctor, you don't have the symptoms any longer, and you go, should I really go or not? Expectations, we'll get to that, very important. Okay, the second part of the model, but really the first pathway to healing, is what we call the real relationship. And the real relationship has been defined kind of in the psychodynamic literature, and it's kind of technical, as the transference-free, genuine relationship based on realistic perceptions. In common language, this is just 2 people meeting, and it's an intimate relationship between those 2 people. We know from research that those people who have good social relationships are also healthier, not just mental health, but physical health. So if you actually grow up with a better social network as children, you have less risk factors for cardiac events and less mortality. So what do we think is the biggest predictor of mortality in the United States? Obesity, smoking, lack of exercise, environmental pollutants. What do you think is the #1 risk factor for mortality of adults in the United States?
Lack of social connection.
Yeah. Perceived loneliness or social support is the biggest killer in the United States. Okay. So, in psychotherapy, a big part of this is the actual social connection between two individuals, particularly for clients who have difficulties with social relationships, chaotic relationships, lack of intimacy in their relationships. This is an important aspect of healing in psychotherapy. Psychotherapy is uniquely enduring. What other relationship do you have in which you can say almost any, the most shameful experience, and the person promises to be there for you in the future, in a empathic way? So I ask my students this, and there's always some student, and I have an image of the student who said it this way. I said, well, I have a relationship like that. I go, well, what relationship is that? He says, well, I can tell anything to my wife, and she's always there for me. Experiment. I want you to go home today and tell your wife you've been having an affair with one of the other students for 2 years. Come back to the class and report how enduring that relationship is. So we think about it kind of humorous, but psychotherapy is pretty amazing that you can tell about those shameful experiences. You can say, I've had an affair. I feel awful about this. I love my spouse, but I did this and I feel terrible. I'm anxious about it. In fact, it was going to rupture my marriage. And the therapist not going to say this is okay for you to do, but is going to understand how painful this is for you. And that's an amazing aspect of psychotherapy. So, again, we'll show a little bit of this. This is Laura Brown, who's the therapist on the right, working with a patient who has substance abuse problems, several relapses, and they're working on kind of a body image. And Laura Brown, did I mention a feminist therapist, kind of very Rogerian in her approach. And we'll watch her display some understanding of how painful this is for the patient.
Look at yourself in the mirror.
I don't see a great-looking woman. I don't see a robust, great, beautiful woman. I just see a fat cow when I look. I can't even look at myself in the mirror now. I just feel so fat. It's sickening. It's horrible.
So I'm going to tell you, when you called yourself that, I just had this jolt of feeling very sad.
Well, I don't feel very good about it either.
No, not that that's how you look, but that you would call yourself that.
That's how I feel, and it's horrible.
So the empathy of understanding how difficult that is for the man. What's interesting from a clinical perspective is the client didn't say, oh, I feel so good for someone to understand me. Kind of went on, well, that's the way I feel. Well, empathy doesn't work all at once. You know, loneliness and poor self-concept is a large bucket of emptiness. And what Laura Brown did as a therapist is put one drop of kind of understanding into that big empty void. It takes a while to build up. It's not going to happen all at once. So this patient over time will benefit from it. It's not going to quit all at once. The science of this, and I'm going to go through this quickly. While I wasn't taking any psychology courses, I was a math major. So I really like numbers as well as people. Okay, so I'm going to show you a few numbers. This is studies that actually meta-analyses, so they combine several studies. Look at how the size of the effect of various factors. Okay, and so on this axis is the size of the effect. So an effect of 0.8 is really, really large. 0.5 to 0.8, yeah, that's a good effect for the social sciences. if you look at empathy and congruence, genuineness, fairly large effects. So those therapists who are empathic can express what Laura Brown expressed in that video also have better outcomes. Okay, okay, the second pathway is around the expectations. So one of the things that happens is in psychotherapy, we create expectations for the patient that they're going to be better, generally, but also that they're going to have an expectation they're going to be able to cope with or deal with their problems. Okay? So for the panic patient, it's not just that I'm not going to ever feel any symptoms of panic, but that I'm going to be able to survive those feelings without excessive worry or avoidance of going out of the house. So expectations have a very strong influence on well-being. And we know this from studies of placebos. Okay? Placebos are inert medications or procedures, right, that have no active ingredients, yet they have very potent influence. Okay, I've got my little joke here on the right. It says, honey, go and talk to him. You see the kid in the bed, because there are 2 tablets and or 2 capsules, and baby's a tablet in the bed. Go and talk to him. He just found out he's a placebo. So placebo analgesics, painkillers, not only do you report less painful feelings, but you release endogenous opioids into the brain, which act as a painkiller. Expectations of less noxious taste light up or change the taste cortex in magnetic resonance imaging. Okay. We thought the taste cortex only responds to sensory input, but no, it responds to expectations as well. It's a really nice study that one of my colleagues at Wisconsin did. Medical treatments delivered surreptitiously out of awareness to patients don't work. So post-operative pain patient, if they see the medical personnel come in and do something to the IV and say, I'm giving you a painkiller, morphine, works much better. They ask for less pain later, even if they're not getting a painkiller. Then if the same medication is delivered automatically without the personnel coming. Irving Kirsch says that he's up to now 95% of the effects of antidepressants are placebo effects. The expectation of the antidepressant is going to make a difference. Okay, well, you're tired of listening to me, so I'm going to give you a little talk about placebo.
Something with no known therapeutic value can actually make people feel better. It's a great trick our minds play on us, that by believing and expecting something to work, it actually does. But what's weird is that the strength of the effect can differ for some really strange reasons. For example, the same placebo can treat pain half as well as aspirin, while at the same time treating pain half as well as morphine. Morphine's a much more powerful painkiller, but a placebo is half as effective as both. Saying a placebo will reduce pain reduces pain, but saying that the same placebo will increase pain increases pain. Believing that a placebo will make you feel better will make you feel better. Believing that it won't has the opposite effect. Now, placebos aren't just pills. They can be creams, injections, surgeries, or drinks. You can even get placebo buttons. They don't actually do anything, but they sure as hell make you feel like you're in control. But not all placebos are equal. The effect of the placebo is bigger when the pill itself is bigger, or if you have 2 instead of 1, or 2 once a day instead of 1 twice a day. And a capsule will usually be a pill, and a syringe will usually be a capsule, and anything with a big ass science machine can outperform any of them. A plain pill works worse than a branded. A discounted pill works worse than a pricey one, and even a pill in a plain box does worse than one that's all shiny and shit. Placebos that are blue work best as downers, and placebos that are red are better as uppers. Studies have shown that people who take their meds on a regular basis are less likely to die than those that don't, even if those meds are all placebos. You can even get addicted to placebos. In one study, a group of women took placebos for more than 5 years. 40% of them suffered withdrawals afterwards. In fact, the effect of placebos can be so strong that some people want them banned from sports. But I mean, how would we even test for that? Placebos don't even seem to work from place to place. For example, in Germany, using a placebo to treat ulcers works better than anywhere else in Europe. But using a placebo that treats hypertension doesn't work nearly as well as it does for its neighbours. Now, remember that all of this is about comparing things that both have nothing medically effective in them, which goes to show that a placebo isn't about what's in it, but about the beliefs that we load onto it. Our minds create the medicine, and that is pretty freaking weird.
Much more entertaining than I could be. All of the things in that video, though, are shown in studies. Really amazing, the effects. And we don't think about it, but there's so many medical procedures that much of the effectiveness is due to the placebo. To get a drug approved by the Food and Drug Administration, it only has to separate from the placebo a small amount, statistically significant, and be safe as well. But most of the effect would still be placebo, and that's the case with a lot of medications. So the expectations that we create in psychotherapy are important as well. So most of the placebo effects are created in interpersonal context. So of course there's some cultural symbols involved, right? The syringe is a more potent symbol than is a pill. But most of this occurs by what the healer says to you. They do these studies of placebo acupuncture. So you feel like you're getting acupuncture, but it's not really breaking the skin. And if you have an empathic healer that gives you that placebo acupuncture, you do much better in terms of your symptoms for irritable bowel syndrome, for instance, but also your general well-being, your quality of life. So the interpersonal context of the placebo is really important. And what we do in psychotherapy as well as medicine is create an agreement about what goes on in the treatment. So when you go to a doctor, you're much more likely to take the medication if you think that the explanation the physician's giving you makes sense. I once had this pain that couldn't be diagnosed. Finally got some doctor to tell me what it was. I was so happy and I got this medication. And I called my brother who's a doctor and I was so excited. And he just says, Bruce, that explanation is totally bogus. Shouldn't have called him. Ruined the placebo. Yeah, I'm going to skip this now because we're going to run out of time. But if we look at, again, the research evidence, the alliance, which is the agreement about the tasks and goals of therapy, and this other variable is called goal consensus and collaboration. For me, they kind of overlap, essentially the same. But these are very strong predictors of the outcome of psychotherapy. So good therapists are able to form relationships and agreement about tasks and goals with a variety of patients, as we say. Okay, the final pathway through which psychotherapy works is through the specific actions. What the patient is induced to do as part of the treatment. So in this way, the relationship's an indirect effect, because the agreement about the task and goal leads to cooperation in whatever the treatment involves. So remember the first two therapists? Okay, Leslie Greenberg had the patient sit and talk to an empty chair. That's not that easy to do. I think it's kind of crazy to talk to an empty chair. And most patients will too. But Leslie Greenberg is really convincing about this. Okay? So he induces the patient to do it, and that then leads to the patient doing something that is good for him or her. Here it's experiencing and expressing healthy affects. Keith Dobson, what did he do? He got the patient to experience a panic attack, okay, or the sensation of it. She actually was rated the symptoms as 7 out of 10. That's a pretty strong. If we watched the whole videotape, she had all the manifestations of a panic attack. Well, panic patients hate that. Yet, Keith induced the patient to do that. So one of the things that all psychotherapies do is to have the patient do something which is healthy for him or her in their life. Some way to get some control over the difficulties or to experience some well-being. But every therapy does it a little bit differently. Cognitive therapy, you're going to quit telling yourself these catastrophizing thoughts. Okay. Somebody doesn't respond to me in a friendly way. Oh God, nobody likes it. Okay. So cognitive therapy will change the way you talk to yourself. Interpersonal therapy, you will work to develop a stronger network of social support with more intimacy in your relationship. Dynamic therapist, you'll understand why your difficulties with intimacy are due to your childhood experiences, and you'll learn how to express more or express behavior that increases intimacy. So therapists get patients to do something which is healthy for themselves. Well, I wrote a book called The Great Psychotherapy Debate, and in this entire model, the only thing we argue about is the debate is right at this little place where some people claim some of these treatments are better than others. So cognitive behavioral therapy is more scientific. It has ingredients that are more potent. And others will claim that no, it doesn't really matter what is done as long as something is done to promote healthy behavior. So are some treatments superior to others? We'll look at this evidence in just a minute. But again, let's come back to these. Two very different therapists doing two very different things. And they both work. So this is the idea of scientific change, and David Barlow says it best. He's trying to differentiate what he calls psychological treatments from something which he calls generic psychotherapy. He says psychological treatments are built on this kind of stuff we've been talking about, therapeutic alliance, the induction of positive expectancies, change, remoralization, which we didn't talk about, but it's just the sense that I'm doing something positive for myself, and that gives some belief that I can do this. So treatments they use this, but importantly, they have specific procedures that are targeted at the deficits that people have. So the notion is somebody with a problem or depressed has some kind of psychological deficit, and we have to figure out how to address that deficit. So if that's true, what David says, then some treatments should be more effective than others. You know, in medicine, now that we have, we know that ulcers are due to a bacteria in our gut, and we have antibiotics that we give to ulcer patients, that works better than the treatment based on this idea of, oh, it's too much acid in the stomach due to stress. Okay, you give antacids as the treatment. Well, if psychotherapy is like medicine, then some treatments ought to be more effective than others. So let's look at treatment differences very quickly, and this is kind of where I got my start in doing research in this area. And it's this notion that, okay, if we look at treatments intended to be therapeutic, they're given by a therapist who believes in them, the therapist is trained to give them, they're not prescribed from doing what they would ordinarily do, and so forth, then all of these treatments are going to be equally effective. It doesn't matter as long as the treatment makes sense to the therapist and to the patient, and the patient believes that this treatment will work. Okay, well, you know, if you do enough studies, students are taking statistics, you'll have some effects due to chance, right? So 5 times out of 100, just by chance, you get a significant effect. So when you look at all the studies, you look at hundreds of them, yeah, there are some studies that showed one treatment was better than another, but just what we would expect by chance. So the Dodo-bird conjecture is, okay, remember the Alice in Wonderland where the dodo bird had people race? They got to start when they wanted and they got to finish when they wanted. And at the end the dodo bird said, all are winners and all must have prizes. That's what psychotherapy is. All psychotherapies, they get to start when they want, finish when they want, and they seem to be all winners, equally effective. So you can find some differences, but again, just about what you expect by chance. So it looks like all psychological treatments, when they're intended to be therapeutic, work equally well. And it doesn't really seem to make a difference for depression, post-traumatic stress disorder, alcohol use disorders. You can have cognitive behavioral therapy, some faith-based therapy like Alcoholics Anonymous, or motivational interview. 3 major approaches, doesn't make any difference. Patients get better at the same rate. Panic, and so on. So if you look at the specific ingredients, whether some particular ingredient for some particular treatment makes a difference, the effect sizes are very, very small. We looked at treatment differences, but it actually, if you take out the ingredient out of a treatment, it still works. So you can take the cognitive components out of cognitive treatment, and it still works just as well. It doesn't matter whether the therapist adheres to the treatment protocol or not, still works. One of the ones that I love is you can have experts rate the competence of the therapist, and that doesn't relate to outcome. So all of these things that relate to the specific ingredients don't seem to make a difference. So what does make a difference? We'll look just briefly at some of this. One of the things that really makes a difference is the therapist. Who gives the treatment makes a difference. So if you look at clinical trials, about 3% of the variability in outcomes is due to the therapist. In clinical trials, you select the best therapists, you train them, you supervise them, you kick them out of the trial if they're not doing the treatment well enough. And 3% doesn't sound a lot, but we'll see that it really is. Okay. It's 3 times as much as differences between treatments. In naturalistic settings, somewhere between 3 and 10% of the variability in outcomes is due to the particular therapist. So we looked at therapists in California in a managed care company. We measured their outcomes. And we just ranked therapists from the best to the worst not based on observing them, because competence doesn't, our judgment really doesn't make a difference. We looked at their actual outcomes with patients. So the best therapist for us is the therapist who had the best outcomes with their patients. It's kind of an empirical definition. We rank ordered them. We looked at the top 25% and the bottom 25%. And then we look, okay, let's look how they do next year. Okay? Well, the top quartile had twice the size of the effect as the bottom quartile in the next year. So we can reliably identify who's best therapists. Good therapists were good with younger patients and older patients, more severe patients, less severe patients, regardless of diagnosis. There's some difference. Some therapists are better with racial and ethnic minority clients than others. Not a big effect, but it's there. So that's the good news. The bad news is there were some therapists that never helped a patient. So in 3 years of data, every single one of their patients deteriorated. Well, we know some lawyers are better than other lawyers. Some engineers are better than others. Some artists are better. Some professors. No. David Saxon and Michael Barkin in the National Health Service in England looked at 119 therapists, and they kind of identified 19 who below average. Well, we know half are below average. These are kind of underperforming therapists. If you just took the patients that saw those 19 therapists, randomly distributed them to the other 100 therapists, 265 out of about 2,000 patients would have recovered, additional recoveries. So it makes a difference. So therapists make a difference. So if you look at therapists in terms of effect size, again, who you get as a therapist, much more important than which treatment you get. Okay. So the question should be, we're running out of time, but we've got to answer. What makes an effective therapist? Okay, if some therapists get better outcomes than other therapists, what is it they do, or who are they? Right? So here's what we know, and I'll go through it just briefly. Good therapists are verbally fluent. They can express themselves well. They're good at reading other people. They can read the affective state. So Laura Brown, very good at this. They're able to express their emotion and regulate them. We could go into the two tapes. Leslie Greenberg is activating affect. He's really good at getting people to express their affect. Keith Dobson, the problem with anxiety patients is their emotions are too high. So he wants to attenuate or reduce the fear response. So he's really good at being really calm in the session, even though he was anxious. He's really expressing calmness. Warmth and acceptance. The therapists are really accepting. This is something we expect all therapists to do. Good therapists focus on the patient, how the patient is doing, their progress, their difficulties is what the focus of the therapy is on. Some therapists, those 19 out of 119, ones that never helped a patient, too involved with themselves. The ability to form alliances with a variety of patients. Good therapists are able to get really difficult patients involved and engaged in therapy. That woman that Laura Brown had maybe 15 or 20 relapses. Okay? They're difficult patients, been through lots of therapy, yet Laura was able to engage the patient successfully. And good therapists are able to cogently give an explanation for the treatment and in a convincing way. So we're supposed to end at 5:30, is that right? 6:30, I'm sorry. So we're just about done. I have one, I guess I'm at the conclusion, so the timing is good. So the conclusion is psychotherapy at its core is a humanistic endeavor. It's there's a great neuropsychologist who studies the neurobiology of sociality. And he said people are evolved to be influenced by other people. And that's what we do in psychotherapy. It uses those evolved characteristics to heal in a social context. There are some internet-based mental health treatments. Some people get better reading self-help books. That's not saying that those are not legitimate ways to change. But psychotherapy is an interaction between humans, really relies on this social aspect of who we are. The type of treatment's not really important. There's a whole emphasis in clinical psychology on which treatment is best. We do hundreds of clinical trials. Over and over again we find basically there's no differences among treatments. But the therapist is critical. Some therapists consistently get better outcomes than others. So, thank you. Do we have time for questions?
I think we have time for a couple of questions.
Okay. Great.
I just had a brief question about the bar graph. What's the study that is that one study or did you pull that from a lot of?
Those are all based on meta-analysis.
Okay.
So the meta-analyses on the common factors on the left were really a book by John Norcross, Psychotherapy of Relationships and Work. Each chapter is a meta-analysis. The common factors are various different other meta-analyses. I'd be glad to send you the references that they're based on.
Okay, great. Well, I don't need that. I just
What happens to the trust level when a patient finds out it's placebo?
Well, it's more than just a placebo. So, I mean, doctors do this all the time. They don't have any problem saying this medication I'm giving you is really effective, even if 90% of the effect is a placebo. Psychotherapy is not simply a placebo. The middle pathway is primary expectation, so there are that kind of placebo effects. You know, placebo effects has this kind of derogatory interpretation, like there's something wrong with it if it's just a placebo. But the expectations have a powerful influence on our well-being. So we really should emphasize that. But psychotherapy is also an enduring relationship. Psychotherapy is also about getting the patient to do something that's really healthy for them in some way. So I don't have any problem with much of the benefit. We don't know if it's more or less than medications. If much of the benefit of psychotherapy is due to expectations, which I guess you could call a placebo effect, I think that's good.
Were there any commonalities among the therapists that didn't have results?
Well,
such as training or lack thereof?
It's not usually training, okay? So we look at training, those therapists who have more training or psychologists versus licensed professional counselors doesn't seem to make a difference, okay? One of the difficulties in studying therapists is that it's really hard to get therapists to participate in the study in which we're going to identify the features of poor therapists. Not surprising. So we don't really know. Some of these studies are pretty ingenious about the list of effective aspects of this. So we really don't have good videotapes where I can show you, here's an ineffective therapist. It's hard to get permission for therapists to say, can I go all over the country show your tape.
If you're in the field long enough, you'll hear the stories from patients
Right.
about what this other therapist said, and you'd have to just scratch your head and go, oh, wow,
Yeah.
really?
It's really, I mean, it's a difficult issue for the field to know what to do with therapists. When I was discussing it earlier, about, we're the only field where you go in and you do the work by yourself. There's no record of what you do. You make notes in your chart, but those are pretty innocuous. Every therapist knows how to write notes. You don't really know what goes on there. It's confidential, right? So what you hear from patients is kind of informative. They'll tell you what the therapist has done. And there are some pretty upsetting kind of stories.
Time for one last question.
Yeah, there was a question in the back, and I thought, yeah. Please.
Yeah, I was just curious, like, what do you put on the bottle when you prescribe someone a placebo? Because, like, nowadays on a prescription bottle it has, like, all the information of what it is. So, how do you do that?
Right. So they don't say 90% of the effect of this medication is due to placebo, right? And in a way, we're glad they don't. So, I mean, in the video, it was kind of interesting. If they'd given Lance Armstrong placebo, he probably would have had the same performance level because of the expectations about the medications. So it's I mean, you're both asking, in a way, the same question. How much do we really talk about that issue with patients? But I think, you know, patients understand that their understanding and expectations of this are important. Maybe if you told them 90% of the effect of this medication is a placebo, that might not be really an effective way to do it. But they have these debates in medicine about whether it's ethical for clinicians to give placebos. You know, by the way, primary care physicians often give placebos. They give antibiotics even though it's not a bacterial infection. And they do it because the patient asked for it and the patient has an expectation it's going to be helpful. So it gets done all the time.
Join me in thanking Dr. Wampold.